Gabrielle. You may know her. She does our maternal depression and PHQ-9 cohort training. So if you've been there, she was our longest speaker. She's the Director of Training and Technical Assistance for Maternal Mental Health NOW. She has worked extensively with new families and aided in providing solutions to many parenting concerns. And she serves as the Los Angeles coordinator for Postpartum Support International and has a private practice in LA, providing services in both English and Spanish. So can we please give Gabrielle a big round of applause?
Good morning, everybody. Thank you for having me. I want to thank the entire LA team for inviting me here. And I want to share the most important news is that there were more potatoes. I mean, for those of us waiting, that was a lot of waiting for potatoes. But I just want to say, on behalf of the potato industry, it was worth it. I have been given the honor of speaking with you this morning about OCD and suicide. Is that exciting? Yes. But my hope is actually that we have some real conversations about some difficult topics without feeling like we have to shy away from it. Because I think some of the difficulties, especially when we deal with topics that are frightening to us, is that we just don't want to deal with them. How many of you have wanted to bury your head in the sand with some of these issues? And I will raise my hand. The rest of you, I'm so proud of you. But I know that sometimes dealing with some of the heaviness that we have to deal with, some of the communities that we work with, and the complexities of the issues make me want to say, oh, you know, enough, right? I can't handle this. So the way I'm going to frame today is we're going to first talk with some depth, a little bit more about these specific areas of mental health that we might want to pay attention to, be aware of, understand a little better. And then in the afternoon, see, I'm already here all day. Now after that, we're going to take a little break, and you guys are all going to try and run away, but I'll bring you back, because in that time period, we're going to look at some fun or interesting or outside the box activities to think about engaging our patients with, or not necessarily patients, but even the families that we serve. How does that sound? Okay, who's got the tambourine? I just love that there's a tambourine here. Okay, so, you've already got the objectives, so I'm not going to take so much time with them, but I just want to bring them up there and let you know that the idea today isn't to walk away and say, okay, I understand all this stuff inside and out. The idea is really that you just have a little more feeling for these issues. And I want to say, I would imagine most of you have been tortured through my trainings before. So those of you who went through the Welcome Baby training and even the Select Home Visitation training, I have done trainings for you before. So I'm going to review some of the same materials, but I'm going to dig a little deeper. All right? So let's start with obsessive compulsive disorder. How many of you have, no, I'm kidding. How many of you have worked with people who you believe struggle with obsessive compulsive disorder? How many of you live with people? No. Look at all the hands that are going. What I love too about some of these disorders is that these days we start to kind of throw terms around. These days, sometimes we throw around diagnoses in the common conversations. You know, oh, that person's house is so clean, they must have OCD, right? You know that? Yeah. No one seems to say that about my house. But, so really, that sense we sometimes take an idea and we overgeneralize it. Having a clean house, as much as it seems completely foreign to the way I live, is not necessarily OCD. OCD is a far more complicated diagnosis and a far more complicated disorder. And so what I really want us to think about, OCD, is all of the words up there. The ones in green, would somebody, Sylvia, right here, would you read the words in green at the very top? This line. You can actually turn around and look at the screen.
Postpartum obsessive compulsive disorder.
How many words are there?
4.
So let's break it down. The hardest one is postpartum. What does that mean? After her. Okay, we're done here. The next word is obsessive compulsive disorder. All of those words are necessary for a diagnosis. Now, I'm not also saying that you need to come out with a diagnosis in working with your families, but you should know that this disorder is a little bit more complicated, a little different than any of the other postpartum disorders. What is obsessive? So let's take a moment to really break down the word obsessive. What does obsessive mean? Okay, I hear lots of things. Can anybody say it loudly? Constantly, say constantly thinking about it. So constantly thinking about something that you can't stop. And actually, did anybody see her hand motion?
Yes.
I use that too. So an obsession is something that really does this, almost like a hamster in a wheel. It just spins. So an obsessive thought is something that's constant and that just really you can't stop. What else? What else is an obsessive thought? What's another way to describe it? Anyone heard the word intrusive? What does intrusive mean? And I'm not talking about your brother, but what does intrusive mean? Yeah.
Like being tapped on the shoulder every few seconds.
Actually, it's a really good metaphor. It's very intrusive. It's like you can't step away from it. I love that image, being tapped on the shoulder, nonstop. How would you feel if you were tapped on the shoulder every few seconds? It's like you can't relax. And that's what happens with an obsessive thought, is that as soon as you start to relax, this I find really often too happens, is that somebody starts to relax or feel a little bit less stressed, and then all of a sudden that tapping comes back. So an obsessive thought is cycling, but it might be quieter at some point and louder at others. But it's really obsessive and intrusive in a way that it's difficult to control. What is a oh, you can't hear. Oh, thank you. What is a compulsion? Yeah.
She was giving me a thumbs up and I was
Oh, you couldn't hear me. But now that your hand's up, you have to answer the question. Because I know you can hear me. What's a compulsion?
act based on emotion?
Yeah, so it's an act based on an emotion. It's really well defined. A compulsion is a behavior. And a behavior, if you think about being compulsive, it's almost a behavior you can't necessarily stop. So you can't stop the thoughts, and you can't stop the behaviors. So the tie between the obsessive and the compulsive behavior, the obsessive thought and the compulsive behavior, is that they are tied together. The obsessive thought is the thought that's intrusive, that taps you on the shoulder, that doesn't go away. And the compulsion is the behavior to try and get some control over that. So that's that. And then what is the last word? Disorder. Why is that up there? Because it's not enough. How many of you have obsessive thoughts? Like, oh my God, did I
Turn off the coffee pot.
turn off the coffee pot? So did you? Okay, so then there's... And how many of us can be compulsive about things, right? I'm compulsively checking to see if I got that great score on the test that I took. But without it getting to the point that it disrupts your functioning, it is not a disorder. So that's why all four of those words are really important. So I want to talk a little bit about when we are talking about postpartum obsessive compulsive disorder, what makes this different than a typical OCD? So how many of you have known somebody who has just a typical OCD presentation, obsessive compulsive disorder? And I know that you guys are here, you wish you weren't sitting here, but will you give an example of a little bit what... You already talked, let's come over here. Yeah.
It's my grandmother-in-law, I guess. She
Go ahead.
sorry. She
So that she can hear you later.
my grandmother would she would wash her hands and then she would go back like constantly where the point where her hands were raw. She would wash them so many times. She even would alcohol the handles of the faucet to make sure they were clean.
That's OCD. So what about, so go through the, we don't know necessarily what the thoughts were. Do you know what the thoughts were with
No,
them?
it got worse because as she got dementia.
And that's an interesting thing too. So OCD behaviors can be fed by compulsion. And let me not go so far off topic to that because I think that's important. But tell us the compulsive behaviors, repeat what they were.
So the behavior was that she, thought her hands weren't clean, so she kept washing them and washing them to the point where they between the cracks.
So the thing about the obsessive thought is she imagined that they weren't clean. And we can't really go into her brain and see what that thought process was. But it sounds to me like nothing would calm that fear. Even washing our hands didn't. And if you think about alcoholing the faucets as well. So I, in my mind, would imagine that for her, she's thinking, oh my God, this may be cleaning, but what's the pipe that's coming out of it? And now I gotta clean this. And the problem with compulsive behaviors with an obsessive thought process is the compulsion doesn't work. It doesn't quell it. So it's not the same thing as, I was just working in my garden, my hands are dirty, I'm going to wash them. They're not so clean, let me wash them a second time, and then you walk away. That's a really different thing than feeling that you can't quell that intrusive tapping on the shoulder all the time fear. And that's where the disorder comes in. Because not only is it dysfunctional, but clearly it wasn't even good for her hands. So it's a wonderful example of a typical OCD, and I imagine her grandmother wasn't in her first year postpartum when that was happening. So somebody else want to share an OCD story? We often think about those cleanliness stories because they're pretty palpable, right? Like we can imagine them. We can see them and we can feel them. Come on, somebody else. I know you have stories. Yes.
So I know somebody who has a pantry, and in the pantry she has all of the cans categorized, and all the labels have to be facing forward. All the boxes are lined up, and they're in an order that she believes they should be in. If anything is used and put back in the wrong place, it's very upsetting, and she has to go back to the beginning and resort them and straighten them. So when you open the cupboard, everything's just very, yeah. And she gets very upset if it's not the right way, and you can't do anything in the kitchen until that is in order.
So again, the obsessive thought, we don't know entirely what that is, but the obsessive thought is this has to be a certain way. The compulsion is the lining up and ordering in that way, but the disorder is exactly the way you described. She can't do anything until that's done. She gets deeply disturbed when that's upset. So that, again, I don't mean to diagnose someone I don't know, but that's a perfect example of that obsessive compulsive. It's one thing, again, do you know anybody who's super organized? We all want a little of that, right? We all want to be more, well, I don't know about you, I want to have a little more organization in my life. And so we all want a little of that organization. And it would be really great to say, oh my God, where are the scissors, and not find them in your kid's bed. But, the thing is, I'm sorry, did I share that story? But no, we really want to be able to find things at home whenever we want to have some sense of organization. Organization is not a disorder. It's this deep distress that comes when things are out of sorts. And you might even find a little about this. How many of you have worked with children with autism? Yeah. Children with autism can display some of this obsessive compulsive behavior. I'm not saying that's the disorder, because the disorder is the autism. But it can manifest in this sense of, I need to know how to expect my day to plan out. And if anything is off, you can watch a child or even an adult with autism break down. Have you ever seen that happen? Yes. You haven't seen that happen? You're a lucky woman. It's hard to watch a kid go through that. It's really disturbing when you see this child just really struggling to get a sense of how to manage those.
They really need routine.
The routine.
To feel safe and secure, and if it's changed, the whole, we just fall apart.
So that sense of routine is like a compulsive behavior with obsessive thoughts. but it's tied to the autism disorder. It isn't necessarily tied to this disorder.
Right.
And I'm, you know, we have this wonderful luxury today to kind of go deep and discuss this. So thank you for having these conversations with me. What I will point out in the postpartum period, the real difference, as opposed to a typical OCD, is that very often by the way, what happened to this table that nobody sat here? Okay. I mean, really? Okay, sorry. I'm just being a little obsessive. But the difference is the obsessive thoughts are very often tied to thinking about the baby. So have you seen an example of that? I know you have. Hang on, I'm going to go back. I got her hand and I'll pass something to the chair. That's good. Okay.
Okay, I'm gonna share a little bit about myself. I don't mind being raw.
Thank you for doing that. That's really brave.
My daughter is 10, so it was 10 years ago. And the hospital sends you home with, I'm not sure if they still do it now, but it was like a chart to track their poopy diapers. I don't know, maybe somebody more recent had a baby. And I became obsessed with this chart. So much so, after I completed the chart that was provided to me, I created my own chart. And I continued to track the poopy diapers for my baby, who was born with jaundice. And so it was like almost being fed to me of, you have to continue to track her diapers, wet diapers, poopy diapers, breastfeed that demand, you know, and so I felt like I was doing what I was being told to do and not really connecting that it was becoming an obsession for me, but it clearly was, because I'm creating my own charts after this. And so that was me. I was obsessed with her diapering, and you know, she's fine. Both my kids are fine. They survived the jaundice and they survived mommy.
But are you still tracking?
I'm not tracking.
Check Facebook.
Baby, no.
I did keep the charts. I'll bring them in.
Is there a clinician in the room? We need to get you to toss those charts. But thank you for sharing your story. I just want to ask, how many poopy diapers happened today with your 10-year-old? But what a wonderful example, because actually what you bring up is, I think, some of the obsessive thoughts come from information we are given by our pediatricians, by the nurses in the hospital. So one of them, for example, is that charting. So I put it up there. I've seen this all really often, is people who get so fixated on how many diapers, and by the way, those poopy diapers, it's not simply did they poop, right? What color? What was the texture? How many ounces of yellow poop did they have, right? And I'm dead serious. And by the way, you know that you really need to have a vacation when you're sitting at the table and talking about it over dinner. So what color was that poop? No, really, I've seen the yellow. It was a yellow brown or the yellow green. You know when those things are happening that it kind of goes overboard. Yes.
I mean, I've been in it, I can talk about it.
You can talk about it.
I've been in a situation like that where they've saved diapers for me when I go as an RN. They line up diapers.
And so what do you think the obsessive thought that goes along with that compulsive behavior is?
I want my baby to be healthy.
I want my baby to be healthy.
Is baby eating enough?
Is baby eating enough? So this goes into the next one too, which is how many people, I have a friend whose baby was born in the NICU. It's incredibly common for people whose babies were born in the NICU to be very compulsive about these charts. Because quite frankly, what are they doing in the NICU? They're like scooping out the poop and waiting, right? You know, they're really taking the time to figure out what the output is of that baby. So when you go home, can you imagine how frightened you are to knowing how to manage this? So she had she was breastfeeding, and she would write down not only what time she did it, but from the beginning to the end. Was it right? Was it left? Did she do left 2 times in a row? At what time at night did she start? Again, keeping track is very different than obsessing and having this compulsive behavior. Because it's a matter of functioning. I want you to hear the word disorder as disruption in functioning, or even disruption in mood. If it creates this anxiety for you, if it creates this high level of stress, then it is in the disorder category more than just, I'm an organized person and I like to keep lists. And I keep them for 15 years. We need to talk about it. But I also, how many of you know that when babies go home from the hospital, they sometimes lose some of their birth weight?
Yeah.
So for some people, that's just natural. They watch it and they do their pediatrician visit, and their weight and everything feels okay. But for some people, that becomes a target to focus on. How do they manage it? I've known people who don't even have any money investing in those baby scales to weigh by the gram because they're so frightened. How about that paperwork you get from the hospital about SIDS? Right?
We all obsess about that a little bit. You don't think your baby's breathing, so you're trying to feel if there's air coming in and out. I've known people put a mirror there.
Yes, to put a mirror there to feel it. So I just want to say that to some degree, and it's a little bit, it's the weighing of compulsive behavior is very different than a compulsive disorder. So to really, I want to drive this home because it's one thing to say, did I put my baby on their back? I'm going to go just one time. But if you check one time, go back to your, living room and you check again, and you go back again and check again and again and again, and you're not ever calmed by that behavior, that's when the obsessive and compulsive go hand in hand. And if you think too, how many of you have heard the news about how flu season is really bad right now? What do you think that does to a new mom? It's terrifying. I was just talking to a mom with a baby who's about to travel, and she's like, oh my God, I'm gonna go on an airplane. And then, even for me, I'm like, good luck with that, but this is how I cheer people up, good luck with that. But really the recognition of there is a sense of where we really want to protect our babies. And I want you to notice too, a lot of these obsessive thoughts come from, I love my baby, I want to protect my baby. It comes from a really good place. But to recognize that in that sense of cleanliness too, or that sense of not wanting to expose to germs. And how many of you can see germs? I don't know, I can see it in the number of Kleenexes my son has blown in the last 3 days, 15 bags. But in general, you cannot see germs. So that only feeds an obsessive compulsive process.
If you have a toddler, you can see germs because their fingerprints are everywhere. They're on the wall.
And the green drip.
Where they, they're on the windows, they're on the top of the table, they're on the backs of chairs. I have a grandchild that comes to my house. I don't have kids at home anymore. And I always know when my daughters come by with a toddler because there are telltale signs everywhere.
So you can see that in a toddler, but in a newborn you might not be able to see it, and you might not, the biggest thing too is, if somebody is, we all know this too, if someone's coming down with something, they're not necessarily sure they're really sick at that point, and they might be at higher risk for contagion, right? I'm not trying to feed your obsessive compulsive behavior. But what I want us to know is somebody who is susceptible. And I actually want to take a moment with that too, because some of us are more susceptible to obsessive thinking. So imagine with me who might be more susceptible.
Mothers with trauma.
Mothers with trauma. Wow, you just hit the nail right on the head.
Oh, because that's what we deal with.
Yes. Mothers with trauma are really susceptible. Because what happens with trauma is we feel dysregulated. And we feel a little out of control. And what does that do to an obsessive thought? It makes you feel like you might not be able to detect. It leads you to doubt your own impulses or your own instincts. So people with trauma tend to be very susceptible. Somebody also who has a history of OCD or a history of an anxiety disorder, they are also more susceptible. So I want to go, did you write, let's write SIDS up there too. What other, oh, you had it. Yeah, no question, it's stupid. No.
Does this disorder have anything to do with chemicals, though?
Yes, actually, it's not a bad question at all. Yeah. Very often there have been studies about people who have obsessive compulsive disorder, and it is about kind of a chemical imbalance. So actually a really good question. And that goes to the question of perinatal mental health in a general sense. Trauma plays a role. Past history plays a role. Chemicals, hormones all play a role in disorders. So it's a as I say, it's a big bowl of soup with a lot of different ingredients, right? There's just a lot adding to it. Okay, so then I want to go to the next area that's maybe a little harder about intrusive thoughts. Because one of the things that we need to know about with OCD is sometimes those intrusive thoughts aren't just about weight or breastfeeding, about diapers, but sometimes they're about even more frightening things. So how many of you remember from when I talked about this before what some of those frightening thoughts might be? I might drop my baby. So can you imagine a mom with a very fragile newborn, a mom who hasn't been sleeping very well? By the way, I'm talking about moms. Dads have postpartum OCD too. But considering here we are with, I'm just going to stick with the moms for the moment, but you can ask about dads afterwards too when I talk to you about that. But, so that fear that you have of dropping the baby. So let's go to that thought process. What would you imagine the thoughts to be?
They're going to die or they're going to hurt themselves.
I'm going to drop, thank you. I'm going to drop my baby. They're going to die. They're going to hurt themselves. And what's going to cause me to drop that baby? I might fall asleep. Okay, how many of you heard the story? Who was it? There was an actress.
Susan Sarandon's daughter.
Susan Sarandon's daughter.
The night nurse, fell asleep on the chair.
The night nurse fell asleep on the chair, and the baby fell and hit his head. Her head, I don't remember. But I remember that story and it being very scandalous. Here's the problem when you hear stories, and this is the problem with media in general, is that media can feed our darkest fears. Because what media tends to do is they take stories that are the things that scare us the most, right? And then they plant in our brain. And if you are susceptible to frightening thoughts, then they fester and grow, and we start to think it might be us. Now, we know that story. We were able to bring up that because it was a famous actor's daughter who went through this. But okay, and so, don't mean to put you on the spot, but I'm sure that fed your fears. How common is that? Not very. But it doesn't matter, because once a thought or an idea implants itself in a mind that's susceptible to having an obsessive thought, it's very hard to shake it. And particularly when, that thought is my goal, my job right now is to protect my baby, and I can't protect my baby. Can you imagine what that does to somebody, that thought process? So that fear of dropping your baby, and then the mom might even visualize further what it looked like when my baby dropped. And I don't mean to be alarming in telling you this, but I want to tell you some of the details, because if you ever hear them, I want you to understand that it's possibly part of her obsessive thought process, and it is not something she wants. It is not something she will do. That's actually the most important thing I want to say. Having a thought is not the same as planning an action. How many of you, when you're driving, have seen a car accident and had a moment of imagining what it would have been like for you to be in that? Does that mean you were in the accident? No. In the same way, somebody who has had a frightening thought about perhaps dropping their baby and then visualizing that baby's head cracking, not at risk for harming her baby, she's far more at risk for something else. What do you think she would do instead? What would the compulsion be if you had a frightening thought like that?
Not holding the baby.
She wouldn't hold the baby. Now, how many of you have taken some training in attachment? What happens if you're not holding the baby? You're not helping the baby grow through that attachment relationship. So there's a real deficit that comes with that. Does that mean the baby is at harm? Yeah, but not in the same way, right? Okay, let me tell you some other stories and images which, again, might sound disturbing, but I need you to hear. I was working with a woman who had a history of OCD, so she recognized it when it came, which was a blessing. But she saw a hammer when she had her baby. Oh, there you go, Sylvia's shaking her head. We already know, right? Where did she go? A woman with a history of OCD sees that hammer and holding her baby in her hands, and it has a terrifying, intrusive thought of using the hammer to hurt her baby. She is disgusted with herself. She thinks of herself as a monster. She's horrified, and she has the insight to know that she has OCD and this happens. So what did she do? Well, she got rid of the hammer, and then she went to the kitchen and she saw knives. What did she do? She got rid of the knives, but that didn't stop the intrusive thoughts. So the next thing she did was decide she probably shouldn't be holding the baby at all. Which goes back to, that's problematic, because she needs to be there for the baby. The baby needs her. So that's the obsessive compulsive in those frightening areas. And I'm going to tell you one area that's even more disturbing in some ways, but I want you to know about it. And then I'm going to take a moment to talk about the difference between that and a psychotic disorder, because I think that's important. And somewhere I laid my clicker. So I want us to think about some of the obsessions that come up. Stabbing, suffocating, throwing, dropping, sexually abusing, and choking your baby. I need you to hear these because it's so important to recognize that these obsessions happen. And is that mom, if it is truly an obsessive compulsive disorder, is she at risk for harming her baby? Very low risk. And I want you to think about the sexually abusing. Who do you imagine is more susceptible? I'm going to go back to your statement anyways. Who is more susceptible to having that frightening image come to them of sexually abusing their baby?
Someone who's been through it.
Someone who's been through it. Someone who's been traumatized, someone who's been molested as a child. How horrifying it is to change that diaper and to have this frightening image and not know what to do about it because they're disgusted by it. So it can cause shame, it can be frightening, and it is deeply disturbing. Now, anyone who's had these disturbing thoughts, how often are they going to come up to you unsolicited and say, hey, I had this really scary thought. I thought about stabbing my baby and I'm horrified by it. How likely is someone to tell you that?
Not very.
Not very. Why? They're scared. They're scared of the DCFS report. Yeah.
Well, the way we were active when we were reading that, you could hear that was rumors.
Yes.
So it causes the shame on some of the children.
So much. So I want to repeat what you said. It was so important. We ourselves react to those words with kind of a visceral response, right? And beyond that, there's a lot of judgment in society. You know, I don't know anything about the story, but there was a headline yesterday about a woman who killed herself, her baby, and her husband. I don't know if anybody, and I don't know anything, I really don't know anything about it, so I don't want to make a comment on the case. But immediately people go to, she had postpartum depression. Now the likelihood that a woman with postpartum depression is going to go on a homicidal rampage is incredibly slim. But if we read that news, how likely are we to share these horrifying thoughts. Because we're afraid we're going to be judged, we're afraid we're going to be locked up, we're afraid the kids are going to be taken away, and we're afraid that we may be deported. And I want you to know that those fears are out there because they are out there for everyone. Really disturbing and frightening. Yeah.
They're not always unfounded either, because I was listening to KRW radio, which is from the Santa Monica College. Public, yeah, it's called public radio. And they were doing a spotlight piece, and they spotlighted a mother who was having intrusive thoughts of smothering her baby. And so she went for her 6-week postpartum check, and she mentioned to the doctor that she was having these thoughts.
Is this the Sacramento mom?
And she kept saying, it might have been, and she kept saying, I'm not going to hurt myself, I'm not going to hurt my baby, but I'm having these thoughts. So then he ended up consulting with someone in his office, and then they reported, and eventually she was taken to the hospital. They took her purse away from her, made her get into a gown, they isolated her in a room. And then they had different people coming and going, interviewing her, observing her with the baby. It took 10 hours for all the different professionals to decide she could go home with her baby. And, you know, this is a person who had no history or anything. And so she was glad that they responded, but the way they responded confirmed all of her deepest fears of telling anyone, but she felt she should tell someone in case she needed treatment, because she thought of psychosis and the freaky things we hear in the news about mothers hurting their babies. And it really backfired on her, but she did get to go home with her baby in the end. But it was a very traumatizing process.
So this woman's name is Jessica Porton. And this was in Sacramento a couple of weeks ago. And actually, I don't think she even shared this idea of smothering. She just said she sometimes just feels angry and a little violent, but she wouldn't hurt her baby. She has plenty of support. And the doctor never saw her. She just saw the nurse practitioner who said, stay here, and then called the police. The police escorted her to the emergency room with her baby, and at the emergency room they assigned a guard to her, and she was never seen by a doctor in the emergency room either. She stayed in the emergency room for 10 hours. They took all of her belongings away. All she had was this baby with her. And this is what came from, eventually a social worker came and said, oh, I don't think you need to be 5150. You don't need to be hospitalized. But here's a stack of papers. Here's a Xerox with some phone numbers. Good luck. Have a nice day. She came to her doctor doing exactly what we tell people to do, right? Go tell your doctor what's going on, and your doctor can help, make a referral, or maybe even give you a prescription or send you to a psychiatrist. And one of the reasons why Welcome Baby is so fantastic is that none of you would do that. All of you know better. But clearly, they haven't invited us to train in Sacramento yet. So, but this is a perfect example of how the medical
Cover your
system...
butt.
Yeah.
Because they were all doing that.
All
liability thing.
They all went immediately to, how can we cover our butts here? How can we... She said the word violent. And apparently no other word she said mattered, right? And that's why we owe families to listen deeper and to ask more. So I'm going to suggest to you how you can ask. I think I have a slide. I'm sorry. I'm going to go. This is the way I ask. I ask this regularly. I say, it is not uncommon for new moms who are struggling to have thoughts that sometimes scare them. Have you ever had any? Now, that doesn't mean they will share, but they're much more likely to if you normalize it. So I'm going to repeat that again. It is not uncommon for new moms to have thoughts that are sometimes scary. Have you ever had that? Now, what would you imagine someone might say?
Yeah.
Yeah. As a matter of fact, I have. Now, if somebody says to you, if I tell you this, Will you promise me you won't take my baby away? I've had that happen. What do you say? You can't promise that. You can't promise that. But you can say, I promise to sit and listen and to try and really figure out what's going on with you so that we can find you the best help. And that's what you say. Because you can't. You know, look, if you feel like if you truly in your heart feel like the baby's in danger, and you know, if you really feel like the baby is in immediate danger, trust your gut. But if you feel that way, you can't say, you know what, in your case, I'm just not going to report, right? We can't make those promises, but we can promise to do what Jessica's doctors didn't do. First of all, see her was the first thing the doctors didn't do. But the second thing is to find out really more. So if somebody says to you, I've had thoughts that are kind of violent. And by the way, one of the signs of postpartum depression that we don't talk enough about is anger. We don't really talk about that. We think, you know, if I were to say depression, what's the first thing you think about? Sad. But in a postpartum depression, there's a great deal of anxiety, and there's a lot of anger.
And she mentioned rocking in a rocking chair, and it was squeaking, and she was holding the baby, and how angry she was getting at that rocking chair. She didn't talk about that.
So it could be that, you know, again, you know, Jessica and I are besties on Facebook, but I don't, no, I'm kidding. We are Facebook friends, but I don't know about besties. I don't know enough about her story. But what I will tell you is that I don't know enough to make a diagnosis. Was it a postpartum depression with anxiety, or was it obsessive compulsive disorder? I don't know. But what I want you to know is that anger can be a symptom of depression. How many of you have ever gotten angry? The rest of you are liars.
How many times a day?
Yes, how many of you got angry this morning? How many of you got angry in traffic? Okay, no, but
That doesn't happen.
what?
That doesn't really happen in this area.
No. How many of you are thrilled that you didn't have to drive into the city for this trip? Yeah. As Terry said earlier, we really recognize after having driven out here, oh, okay, you guys are heroes for driving out. So I want you to go back again, and I know that by the way, am I driving y'all crazy yet? Okay, good, because I really want to hammer a little bit more in, and I hammer's the wrong word. I want to bring down that point really clearly, that we just hearing a single word out of context isn't enough to come up with a diagnosis. Find out what's behind it. See what the distress is. A mother who is psychotic may feel agitated, but she's not going to necessarily feel badly about having a thought of bringing harm. So it's a very different experience. So the next slide I have is about the difference between OCD and psychosis. So the difference between OCD and psychosis is very different. And the way you'll feel it the most is in your tripas, right? In your gut. You're going to find it in that way that you go, oh, something is way off here. That's the psychosis. It feels wrong. Your skin's kind of crawling. You don't feel safe with this individual. And I'm serious. Anyone ever been with someone who's psychotic? It feels very disorienting and disturbing. It is a very different experience. And somebody in a psychotic state should not necessarily be trusted with their baby or even with their own safety. You don't want to leave them alone. However, somebody who is experiencing an obsessive compulsive disorder and having frightening intrusive thoughts, they're in a very different place. So you might really want to check into, how does she feel about having these thoughts? Really ask directly, wow, you've had those thoughts? How does it make you feel when you have them? And most likely, if it's an obsessive compulsive thought, she will say, I feel horrible. I feel embarrassed. I feel like I'm a terrible mom. I feel like I shouldn't be the one to do this. I don't know what I'm doing here. I'm so overwhelmed by these thoughts. That's OCD. So before I move on from here, how many of you feel like you get this better than you did earlier?
Yes.
Okay. So, and I think it's an important thing to say, hey, we put out a number between 2 and 5%, but I think that's a big fat lie, because I think that people who are experiencing truly disturbing, intrusive thoughts are not going to be as likely to share it with you, for all the reasons that we noted before. Okay, so I want us to know that. The thoughts that come along with the psychosis are a lot more bizarre in feel. And here's the thing, anyone says anything to you that talks about an intrusive thought or even a psychotic thought, check it out with a supervisor. How many people are in this room today? How many of the people, nobody knows the answer. You're all supposed to raise your hand here, right? How many people in this room have a supervisor? I want you to become comfortable saying, you know, I really don't understand what's going on in this case, or my gut tells me everything's okay. I just want to check it out with you. And you can just say, Gabrielle told me to do it. Blame me, that's kind of the thing I say lately, just blame me. So I'm going to move on to the next topic, but before I do, I just want to make sure you get it. Okay, so what are the things that you can do to help her? Here's the phrasing.
Oh, so you said,
Yeah.
you said having scary thoughts is not uncommon for postpartum moms. Have you ever had thoughts like that?
Right, and that's up there. And so it's here in this book. Thank you. See, Sylvia's listening.
Yes.
As are you all. Okay, normalizing behavior is really important, but that doesn't mean she doesn't need to get help. So here's the thing, when you say it's not uncommon, the answer is not, okay, you're going through it, other people go through it, have a nice day. This is really hard, let's see if we can find you some help. Again, don't promise that you won't report, seek supervision, and then really talk to her about safety. If you don't feel safe with your baby, let's figure out what we can do, because we want you to be able to enjoy spending time with your baby. What can we do to help you with that? What will ease your mind? Maybe at the beginning, spending time with your baby will have to be with someone else present for a while. You have to be creative in these areas. Maybe we need to show you how to hold your baby while you're sitting down so that you don't have to worry about your baby falling. One of the things I do really regularly too is when somebody is willing to share, I sincerely think, wow, that must have been really hard for you to share with me. I am so appreciative that you would share that with me, and I'm going to do my best to help you. Again, you're not promising I won't ever report this, but you probably won't need to, but you still have to be cautious. And then if you truly are concerned, seek supervision, or if even you're partly concerned, seek supervision. Okay? All right. How y'all feeling? Since we've talked about obsessive compulsive disorders, now we're going to go to talk about suicide. Didn't they give me the great topics? So, let's talk a little bit about suicidal ideation. One of the things you should know is that suicide is the second leading cause of postpartum maternal death. Did anybody know that? I don't know what the first is, but it's really common. Women during the perinatal period are in a highly vulnerable state for mental health issues, including suicidal thought. Postpartum women with a history of depression are at 70% greater risk for suicide. % of women report suicidal ideation during pregnancy or postpartum. So are you getting the idea that this is a pretty common issue? This is an issue we need to be paying attention to. Now, I also want to take some time, and I will later, differentiating between suicidal thought and suicidal act. Okay, this is the World Health Organization had this quote, but I'm going to spill it out a little bit more, which is that they had an actual number. One, suicide intimately affects many other people who become survivors.
Yes, I can vouch for that.
You can vouch for that.
My mother, before before Abby was born, killed himself. I think he didn't want his daughter to see him like that.
So that impact is not just, on the immediate family, but that impact, I think about it like a pebble in the river, the ripples that come from that, and they only grow and expand. Untreated depression is the #1 reason for suicide.
Wow.
But here, who can flip that statement on itself? Treated depression actually works. Not for every case, but can you imagine how we could change things if we looked at depression as something we would talk about more regularly and address and provide treatment for without the stigma? How could we reduce the number of suicides? This is an interesting one, and I actually want to tell you that this statistic comes a lot from looking at the number of suicides with military and veterans, which is super high. Every 14 minutes, someone dies by suicide. I'm going to teach you something today I want you to learn. Don't use commit suicide anymore. Why? Yeah, well, so there's that sense of committing. But committing puts it out there as if you are deciding to commit to suicide. Most people who die by suicide, they are actually really dying because of their depression. What would it be like to say they died from depression? Because the cause of their death was really something much greater than the act of their death. So you could say suicided or died by suicide, or even you could say died from depression. I think that does a little more to honor and also to reduce the stigma related to depression, because that goes back to the other slide. The #1 cause of suicide is untreated depression. So if we could treat the depression, we could do something to change. So I think this is a really important thing. A colleague, okay, this is fantastic. There's this colleague of mine, her name is Gabrielle Kaufman, that's her last name. But she has some wonderful quotes, and I have her in here a couple of times. This is her suicide logic. All right, so this is the logic in the brain of somebody who is postpartum and who has decided that suicide is what she should be doing. Her logic goes like this. I am a terrible mother. I'm going to go back a little bit. Let's think about OCD for a moment. I'm a terrible mother because I had a thought of stabbing my baby. I had a thought of violating my baby. I had a thought that really scared me. I'm a terrible mother. Okay? So what that means is that my husband and baby deserve better. Right? So let's follow that logic and that equation. I want you almost to think about it like a math problem, right? So, I'm a terrible mother, my baby and husband deserve better, and so they will really be better off without myself. So, I need to die. I need to kill myself. I need to not be part of the picture. Can you imagine that logic? Does that make sense to you? Can you see how that would be the way someone might think if they were deeply depressed? And in a way, I think about depression a little bit almost like a fog, because it comes in with this conviction, right? There's so much conviction in this statement. How many of you did the good mom, bad mom exercise with me? How many of you remember that? So in that exercise, we really talked about this idea of good. I mean, my best friend wrote me a text yesterday saying, I'm a really bad mom. I don't even remember what her infraction was, but it was maybe that she decided not to go to a parent-teacher conference or something like that. But we are always saying, I'm a bad mom. But if it comes to the point where you cannot shake that thought, you are convinced of that thought, it can bring you into this equation. So now I want to tell you something really cool about Yael. New York Times, I think either last weekend or very recently, put together some really interesting little videos, animated videos about parenthood And Yael's story is in there about her suicidal thought. I will see if I can try and find the link and give it to you.
I have that actually.
Oh, you have it.
Yeah.
So you know what I'm talking about,
I do.
right? Did you see her story?
And we'll post it with this video.
Okay.
Here.
Her story is fascinating, and the interesting thing about her story is that it's intergenerational. So her suicidal thoughts came from the fact that her mother died by suicide. So when she, either right when she was born or when she was very little, I don't remember exactly. And it's an incredibly powerful little snippet. I thought it was amazing. And it was interesting, I saw it and I'm like, I wonder if that's her. And I reached out to her and she said, yeah, that's me. That was really cool. So, how are people in the perinatal period choosing to use their attempt suicide? What are the ways that are most frequently used? So mostly it's medications. Now I want to talk a little bit about those medications. I just talked to a client who I've been working with for a while who has had a long history of suicidal thought. And I outright asked her, have you thought about how you would do it? And she said, yeah, this summer my son had surgery to have his adenoids out and they gave me liquid painkillers. And he doesn't need it anymore and it's in my medicine cabinet and every day I look at the medicine cabinet and I open it up and I see that whole bottle. And I think that's how I would do it. What do you think of that? She has a plan, she has the means. She knows how she's going to do it and she has access to it. She promised me, and I'm sharing the story with you so you know what a terrible therapist I am. She promised me that she was going to take this bottle and give it to her husband to dispose of. When I spoke to her later, I said, so what happened with that? Oh, I never did it. So I had to kind of go, it's not enough then for you to promise. I might need to walk with you through that process. But in some ways for her, that medication is almost her safety. When things get really bad, that will always be there for her. But let's go back in a way to this equation. Why would she need it if she believed that she was a good mother? Why would she need it if she felt some sense of hope? So to kind of think about what are the ways in which we might want to build that hope. So it's in women, by the way, suicide attempts or suicide methods are most likely going to be taking medication or an overdose of some sort, much less use a violent means like a gun. But don't be afraid to ask if there's a gun at home. By the way, I just did a training in Vegas. A lot more of them have guns at home. So to really think about if that gun is there, is that in their thought process? Are they thinking about that? By the way, if you're thinking about men are much more likely to use more violent means. It might be a vehicle, it might be driving, it might be asphyxiating, or it might be using a gun. And let me take a moment to check in with you all. This stuff is heavy. It's heavy, it's hard to deal with, and I would imagine that at least some of you have known somebody who's died by suicide. So I just want to be cognizant of that and aware that that's something that might be touching you at the moment. I don't mean to be callous in talking about these issues, because I don't think that. I think instead it's important for us to not be afraid to talk about these issues. So in the postpartum period, people are more likely in the first month, and then I think it's interesting, and in the 10th and in the 12th month. So I don't know the reasons, but my guess is that first month, which is completely overwhelming, and they're dealing with a flood of emotions and struggles, that's a tough time. And then my gut tells me that 12 months later, they've said, oh my goodness, this has not gone away. And that's when the hopelessness really kicks in too. This will never go away.